Hi, my name is Linda Hamrick, and I am going to discuss a single case design with my client Bob Smith. Bob Smith is a 26-year-old white male. He is single and does not have any children. He just currently moved back home with his mother and father. And Bob has anxiety issues. That is what has brought him to me. His anxiety has cost him relationships and jobs. He's never sought treatment before for his anxiety until now. At Bob's last checkup, he didn't have any health problems. Although he is a smoker, Bob doesn't have any history of drug or alcohol abuse and only drinks on occasion. Bob was living with a roommate until they got into a physical altercation, and that is what brought him back to his parents' house. There's been no prior physical or sexual abuse ever reported in his past. Bob is a high school graduate. He has 1 semester of college completed. Bob does attend church with his parents and stated that the pastor has helped him work through issues in the past, and he is hopeful about having that spiritual guidance in his future. Bob is also currently employed at Rubber Buttons. I looked at a problem-solving and CBT model when I approached Bob. Both are very similar in dealing with immediate problems of the client, and both models use awareness techniques and both utilize the core conditions of empathy and unconditional positive regard. One disadvantage to this model is if Mr. Smith's issues stem from something deeper in his past, those issues would need to be addressed before he can move forward. And also, if Mr. Smith is suffering from clinical depression, he may need longer-term therapy. His problem list is Mr. Smith is feeling anxious and depressed. He has been arguing with his parents since he's moved back home, and he has lack of motivation. We used an individual rating scale for 2 weeks just to measure, just to get an idea of Bob arguing with his parents. How often was this happening? Was there anxiety and stress involved? So that's what, it was a triangulation, because not only did I ask Bob to record his outburst with his parents, but also for his parents to observe and record it also. One of the reasons why is because Bob may not think that his, what he says to his parents, he may not view that as being an angry outburst, whereas they do. By having Mom and Dad contribute to this observation log, it gives the data more validity than if Bob just self-reported. And like I said before, it's just maximizing triangulation, and measuring the data is stronger and reliable. I also used a perceived stress scale from the very beginning. A perceived stress scale has 10 different questions on it. You can shorten the scale to 4 questions, to 2, 4, 5, and 10. 2 of those questions have a positive statement to them, and the other 2 are negative feelings. And how you score that, with the positive statements, you would reverse the scores. The score is 0 to 4, 0 meaning never, and then 4 is most often. So if someone scored on question number 4, since it's a positive statement, in the last month, how often have you felt confident about your ability to handle your personal problems? If Bob Smith said 0, he gave a score of 0 because he never felt that way, you would reverse that to a 4. And if he gave a, a 3, you would reverse that to a 1, and so on. The validity and reliability of the perceived stress score. Higher PSS scores have been associated with failure to quit smoking, failure among diabetics, to control blood sugar levels, and greater vulnerability to stressful life elicited depressive symptoms. It's also temporal in nature because levels of appraised stress should be influenced by daily hassles, major events, and changes in coping resources. Predict the validity, of the PSS is expected to fall off rapidly after 4 to 8 weeks. So, Bob's goals, he wanted to relieve stress and anxiety. His objectives would be that he would not argue and have angry outbursts at his parents. This is how he would tell if it was working, and his PSS score would be less than 10 each week. Evaluation and design. This type of single case design is an AB with delayed change. The reason why I chose AB is because once the intervention was implemented, it was 2 weeks before the client started reporting positive changes. This could have been due to a maturation effect, not necessarily the intervention in itself. Bob came out of a very conflictual environment, and he came back home to his parents where it's possible there could have been some transference in the beginning with the arguing with his parents, because that was happening a lot in the first 2 weeks. But then we implemented the intervention, but also it could just be that Bob was at home and he was away from the bad environment, and he started getting into the routine of being around his parents and being in that kind of loving environment. I could have tested this design to see if he was indeed experiencing the maturation effect. I could have checked that validity by using an ABA design. That would require removing the intervention. I did not do that at this time, one, because I didn't have a lot of time with this client, and also because he was improving, and I didn't want to take the intervention away and see if things changed. So the intervention was to exercise in nature for 1 hour daily. He was also to keep a thought journal and go to bed in enough time to get 7 hours of sleep nightly. I looked at an article. It's called Exercise Therapy for Patients with Psychiatric Disorders, Research and Clinical Implications. This was by Greg Tkachuk and Gary Martin. This was a very interesting article, and they looked at different aerobic exercise, strength training, and also meditation with different disorders and depression and anxiety. So what they found out is that regular exercise is a cost-effective intervention. It's way cheaper than trying to put someone on an antidepressant or hospitalization, which of course if someone is having a major depressive episode or bipolar or schizophrenia, those medications, exercise is not necessarily going to work for those. It also is, strength training is as effective as regular exercise, and it is more effective than a placebo and more effective than CBT therapy. Something you have to keep in mind is you need to explore the client's history and see what kind of health they're in. If they are in bad health and they are trying to just start this like hardcore exercise regimen, you need to take that into account because there could be complications to that. So also the therapist could participate. Maybe a therapy session could be held while you're walking around in the park or on a greenway, different things like that. So it's not just limited to being in your office and seeing your client in that session. There's other things that you can do to model that behavior with them. And help client choose enjoyable activities. And that involves conversation and finding out what they really like. You know, maybe when they were a child, it was something like kickball that they really enjoyed. And how could you make that, how could you help them find other people that would enjoy having a kickball game. So it's just kind of being creative and thinking outside the box. Not everybody wants to walk or hike. There's other things that they might enjoy more, but it's still physical exercise outside. And also, you should consider what other kind of options there are if say, their place of employment's not far from their home. Maybe 1 or 2 days a week they could walk there instead of driving, or if there's a YMCA close or a greenway. So it's just really kind of looking around and brainstorming with your client to find out what would work best for them. So my data analysis, my graph did not want to show up on my PowerPoint, so here it is. And as you can see, the data points at the baseline, and up here is the outcome, and the goal is 8. For the perceived stress scale, we want the scale to score 8 or below each week to show that their stress level is coming down. So as you can see, my client started out at 12. And then as the intervention kicked in, he went down to 10, and then 8, and 8, and then 5. So my conclusion is, my results, if I didn't factor in anything else, it would look from my graph and from my data collection that this intervention worked. And that's all it took for him to relieve his anxiety and angry outbursts with his parents, that all that stopped because he was getting exercise and he was journaling his his thoughts and feelings and what was making him angry and how he could change that. I don't necessarily know if that's true in evaluating this study, because my customer came, like I said in the beginning of this video, he came from a very conflictual environment. He had a roommate that maybe had some drug problems, and so they were fighting and arguing all the time, and it finally blew up into a physical confrontation. So, of course, living in those kind of conditions is going to cause a lot of anxiety, panic attacks, make you angry. And then coming home to parents, I think he still carried a lot of the anger with him. And once he was at home and just getting back into the routine and just around people that cared about him and did not want to fight with him all the time and didn't have these other kind of issues of substance abuse and alcohol abuse, he just kind of leveled out. So, I mean, it's kind of skewed. Either the intervention worked, or maybe it was a combination of the intervention and the environment, that helped my client really start to feel better. So that kind of covers my results, my strengths, and my weaknesses. And what did I learn from this? I learned that data collection is so imperative to knowing if something is working or not. Graphs are definitely not something that I enjoy, but I understand the importance, because if I had a breakthrough intervention, how could I share that and show that it's evidence-based practice if I don't have the data to back it up? So I just want to thank you for your time, and I appreciate you listening to me. Thanks so much.